Hello, this is Dr. Kim Jeong-gil. Today, we will be covering the first part of arch length preservation, which is transpalatal arch. Arch length preservation can be divided into three parts: preserving arch length, maintaining space, and regaining space. At first, if the primary molar remains, arch length preservation is required. If the primary molar was extracted, it could be classified into two types. If there is enough space, you should keep it. Unless there is sufficient space, you should regain it. There are two cases. In the picture above, the canine, the first premolar, and the second premolar are exchanging. In the picture below, the primary second premolar remains and the second premolar is erupting. At this time, it is a concern whether to use the primary second molar space. Dr. McNamara said that TPA would be placed for more than nearly 90% of the patients before maxillary primary second molars fall out. When it is necessary to preserve leeway space in the mandible, using the lingual arch is recommended. Because Westerners tend to have a larger nose, non-extraction cases are common. On the other hand, Asians have limitations to non-extraction treatment. In this patient, we can observe that there is minor crowding in the mandibular anterior teeth, and the primary second molar remains. As you know, the erupting second premolar is smaller than the primary second molar. Even if there is a crowding in the anterior region, you can use this space. In this case, the mandibular second molar is erupting after exchanging the permanent teeth. How do we treat this without extraction? If the anterior teeth are moved forward, as it becomes unaesthetic, so the mandibular first molar must be moved posteriorly. At this point, it might cause impacted mandibular second molar. In MEAW orthodontics, treatment must start after eruption of the mandibular second molar. After the mandibular second molar erupts, then the second molar can be pushed back. If there is mandibular anterior crowding like this case, and the lateral tooth exchange is completed, it is highly likely that the premolar would be extracted. If crowding is not severe and the primary second molar remains, decrowding is possible while maintaining the current facial and anterior position by using the primary second molar space. Let's have a look at the terms. Arch length, distance from maxillary central incisor contact point to maxillary permanent first molar or maxillary primary second molar distal surface. Arch width, the distance between the primary second molar or the distance between the permanent first molar. Arch perimeter, distance of the line that connects tooth contact points between the primary second molars. The arch length decreases by 2 to 3 mm while exchanging 3, 4, and 5 teeth during the 10 to 14 years old in the mixed dentition period. As the deciduous teeth fall out and the permanent teeth come out, the anterior teeth are moved slightly backward, and the posterior teeth are moved forward more. The mandibular arch perimeter also decreased by 3.5 mm in boys and 4.5 mm in girls. Interestingly, the mandibular arch length is maintained until the canine replacement period. Therefore, if the mandibular canine remains, it is desirable to maintain it until it falls out naturally. Now let's take a look at the leeway space. The sum of the widths of crowns C, D and E is bigger than the sum of the widths of crowns 3, 4 and 5. It is 1.0 mm in the maxilla and 1.7 mm in the mandible, bigger per unilateral. Interestingly, primary teeth D and E are larger than premolar. But primary tooth is smaller than canine. Therefore, if the mandibular canine erupts and there is mild anterior crowding, non-extraction treatment can be performed by using space D and E. Mandibular primary second molar is 2 mm larger than the mandibular second premolar. Maxillary primary second molar is 1.5 mm larger than the maxillary second premolar. Mandibular primary first molar is 0.5 mm larger than the mandibular first premolar. If the amount of mandibular anterior crowding is 4 to 5 mm after the mandibular canine erupts, 2.5 mm of leeway space per unilateral of the mandible can be used. Maintaining the arch length in the mixed dentition period allows subsequent permanent teeth to erupt well. We can obtain good results by using leeway space, considering the anterior crowding. Let's have a look at the terms. Hellman's dental age. The stages of development can be divided into 7 stages. A stands attainment, when the eruption is done. C stands for commencement, when the eruption begins. 2 A contains A, which means that the eruption is all done. This is the time when the deciduous dentition is completed. Around the age of 5 to 7, the anterior teeth and the first molar begin to erupt. It is 2T containing C because it is start of eruption. Next, 3A is the time when the permanent anterior teeth and the first molar eruption is completed. 3T is the time when the second molar eruption begins. But in the middle, there is stage 3B. It is the time when the lateral teeth are exchanged. Since 4A contains A, it is the time when it is completed. It is when the permanent second molar eruption is completed. Like this, the stages of tooth development are categorized based on Hellman's dental age. T is the start of eruption and A is the period of completion. Among Hellman's dental age, 3B is the time when C, D and E exchange. Early mesial shift. In deciduous dentition, a space appears in the maxillary and mandibular anterior region. In the mandible, when the mandibular first molar erupts, primate space closes. Primate space is a space that primates have. It is in the maxillary canine mesial and in the mandibular canine distal. Early mesial shift is when the space in between the distal end of the mandibular canine is filled. As a result, the flush terminal plane of deciduous dentition turns into a class 1 relationship. Late mesial shift means that maxillomandibular first molar moves to the mesial while primary molar is exchanging. In this case, we can use leeway space. The mandibular primary second premolar is about 2 mm larger than the second premolar. So we can gain 2 mm per subunilateral and 4 mm total for both sides. What problems will arise if the teeth fall out prematurely? First, there is not enough space to erupt for the subsequent permanent teeth, so it is likely to have crowding. Second, due to the difference between the left and right vertical dimension, midline deviation may occur. Therefore, it is necessary to maintain space or gain space if the teeth fall out prematurely. These are cases showing crowding in maxilla and mandible. Does it need a treatment? How should we treat it? First, evaluate the arch length discrepancy. For arch length preservation, use TPA for the maxilla and lingual arch for the mandible. Arch length regaining is required if there is insufficient space due to missing teeth. In non-extraction cases, arch length preservation or arch length regaining can be performed. What do we do in extraction cases? Serial extraction, which means step-by-step extraction for helping subsequent permanent teeth erupt well, is desirable. This is an evaluation stage to determine extraction or non-extraction in adolescents and adults. In what cases should teeth be extracted? First, in the case of aesthetically slightly protruding lips. Second, in the case of high angle where the combination factor is small. Third, in the cases of crowding observed in the mandibular anterior region, the premolar is likely to be extracted. When preserving the arch length, evaluation of the maxillary and mandibular anterior crowding are required. The presence or absence of mandibular anterior crowding is important for non-extraction treatment. Therefore, lingual arch is used more often than TPA in clinical practice. This patient has slightly protruding lips. The crowding is observed in the mandibular anterior region and in the maxillary anterior region. Lateral teeth are in exchange. But the combination factor is small at 150. It means high angle. Which one do you think is better, preserving the space or extracting teeth? This patient has slight protrusive lips. The anterior crowding is not severe. The combination factor is large at 158. It is low angle. Patients like this should be treated with non-extraction. Fortunately, this patient does not show an anterior crowding. If there is an anterior crowding, a lingual arch may be required in the mandible to maintain the space. If there is not anterior crowding, you do not need to place a lingual arch. Whether to preserve the arch length depends on the state of extraction. For non-extraction cases, it is recommended to preserve the space, even for the cases of borderline for non-extraction and extraction. It is recommended to reevaluate after preserving the space before extraction. The main device used to maintain the maxillary space is the Nance holding arch. It consists of a band at maxillary first molars and 0.9 mm palatal arch wire. Due to the food impaction under the palatal acrylic resin, it is likely to be palatal irritation and hard to manage oral hygiene. To resolve the shortcoming, transpalatal arch TPA is used. It is banded at maxillary first molars and soldered with 0.9 mm transpalatal arch wire. There are two types of TPA, fixed type and removable type. Removable type welds the tube to the lingual side so that the transpalatal arch wire is removable. On the other hand, the fixed type is fixed by soldering the transpalatal arch wire to the band. Also, TPA is divided into banded type and bonded type. The loop direction of the TPA can face either forward or backward. In the case of that, TPA is applied to maxillary first molars. To extract the first premolar and maximally retract the anterior teeth, the posterior teeth may be moved slightly anteriorly. If the loop is facing forward, the loop can press the palate when moving the posterior teeth forward. So the loop should be facing backwards. On the other hand, in class 3 malocclusion, the loop is placed facing forwards to correct the position of the tongue. When doing TPA, you should evaluate whether the buccal sides of the left and right maxillary first molars are parallel. Then, the line connecting the distobuccal cusp and the mesolingual cusp of the maxillary first molars passes through the contralateral canine. However, the case like the picture on the right is called the mesial rotation of the first molar. The buccal sides of both first molar teeth are not parallel, and the mesobuccal cusp is pointing inward. In this case, the line connecting the distobuccal cusp and the mesolingual cusp of the maxillary first molar is located behind the canine. if the first molar is mesially rotated. It can be adjusted by using TPA so that the mesobuccal cusp is pointing outward. This makes it possible to make the buccal side of the left and right first molars parallel. This is how to adjust TPA. You will activate one side first. Like A and B, the first molar is mesially rotated and the crown is buccally inclined. In the end, you want to have results like E and F. To do this, first hold the TPA like shear and adjust the buccal side to be parallel. Then, hold the band like D and apply the buccal root torque crown lingual torque. Adjust one side first and adjust the other side in the same way in 4 weeks. At the end, you have to make sure that the buccal side should be parallel in the TPA band. If the crown is inclined to the buccal side, it must be adjusted to a normal shape. The problem with TPA is decalcification. If the band is used for too long, as shown in this patient, the first molar may be decalcified, and in severe cases, caries treatment may be required. To prevent this, it is recommended that you use TPA for the minimum period. If long-term usage of TPA is inevitable, band removal, oral care, and re-cementation should be carried out at least every 6 months to a year. Let's review. You can use leeway space when lateral teeth are being exchanged. In the mandible, 2 mm of the primary second molar and 0.5 mm of the primary first molar, i.e., 2.5 mm per side are available. In the maxilla, 1.5 mm space of the primary second molar can be used. These are indications for TPA. 1. When maintaining space. 2. In the case of derotation of the maxillary first molar. 3. In the case of reinforcing anchorage. 4. When intruding the maxillary first molar is necessary. 5. In the case of traction for the impacted maxillary anteriors and canine. 6. It can be used to solve the scissor bite. The TPA indications will be given in detail in the second part. Thank you for watching.